we are going to discuss about indirect ophthalmoscopy. Sometimes we call it IND. I don't know the short forms, but it's definitely indirect ophthalmoscopy. So indirect ophthalmoscopy means the combination of condensing lens and with the direct ophthalmoscope. Okay, or maybe with the slit lamp, or maybe with the headband, and there are many things. Okay, we can do monocular or binocular, but definitely it's binocular is major advantage, isn't it? So what we need is major thing, we need a condensing lens, isn't it? So clinical consideration is when to use indirect ophthalmoscopy is the main important whenever we suspect peripheral retinal changes, because in direct ophthalmoscopy peripheral changes is quite difficult. And whenever there is a distortion secondary to high astigmatism or high myopia, yes, definitely, and explain the loss of visual acuity, unexplained loss of visual acuity in this case, dense or cloudy media at that particular point, the light intensity from slit lamp, it's easier, isn't it? So macular changes are not confirmed direct ophthalmoscopy, yes, but not that much, because direct ophthalmoscopy is far better in case of macular changes, particular point if you want to see. But in direct ophthalmoscopy, and they have their own advantages. So patient with hypertension or diabetic mellitus, yes, to screen patient in a short time. So indirect ophthalmoscopy very useful in patient having history of fluorescence flashes, definitely high myopia. If you want to see the myopic changes in fundus, then definitely it's better choice. So what is the optical principle of see? This is the very important concept you have to understand. See, first you put this high power plus lens. That's why I make the eye highly myopic by placing strongly convincing lens. If you put plus lens in front of any patient's eye, then that eye becomes myopic, isn't it? So if you place highly high strong plus power, then eye become more myopic, isn't it? So strong convex lens in front of the patient's eye, and the emerging light ray from the area of fundus brought to focus, real and inverted, the image between the lens and observer. See, this is the retina, and as we have discussed, the light exiting from retina in that direction will go parallel if it is emmetropic, will go diverge if it is hyperopic, or will go converge if it is myopic. Whatever light it goes, when it comes to this condensing lens, then its focus will be here, isn't it? Will be here. What is this plane? So this is the plane in which image of the retina is formed, and that plane is intermediate image plane, and it lies between observer, that's our optometrist eye or ophthalmologist eye, and maybe here slit lamp, maybe slit here, but image is here. Now if slit lamp or headband, we will focus on this image. Okay, this image, that image made by this condensing lens. That's the concept. So that's why we called it indirect, because we are not directly seeing retina, but we seeing image of retina made by condensing lens through slit lamp or headband or whatever. So then what do we call this? Called not direct. Then we call it indirect, because it's we are not directly seeing retina like direct ophthalmoscope. That's the concept of indirect. Indirect means we are seeing image of a retina made by highly condensing lens. Okay, that's the concept why we call it indirect. Monocular indirect ophthalmoscopy, and I think I have not seen this instrument. Simplest form of indirect ophthalmoscopy. Direct ophthalmoscopy is held on the arm length and patient's eye, and condensing lens is placed in front of the eye. Most useful when the patient's pupil will not or cannot be dilated. Okay, it's just direct ophthalmoscopy. Just hold the what do you call it? 20 diopter. If you hold 20 diopter plus 20 diopter in front of patient's eye, dilating eye, and if you just show torchlight, you can see the retina, isn't it? So that's even better. So sometimes you can see the retina, isn't it? That's not a big deal. Okay. So principle of monocular indirect ophthalmoscopy. Illuminating system consists of condensing lens system and image source in the beam splitter, and patient ocular observation system consists of telescopic engine, focus, and observance eyepiece. Okay, this is very simple. It's always there, isn't it? So iris diagram to control the amount of light into the patients, and focus eye eyepiece to allow the examiners to overcome. So basically, there is a light source, and that this mirror throws the light to the retina, and from retina light came, and this condensing system and creates the image somewhere which is between observer's eye and between patient's eye, and we focus on this in not directly but indirectly retina's image, and that's why it called indirect ophthalmoscopy. So basically characteristics made by plus lens, that's why real inverted image, and relay on the system is relay system is erected basically if there is a system that will invert the inverted image, and then it will be magnification is divided by the refractive power of the eye to the condensing age. Very simple. So I'll show you. See, 20 diopter means 3 times magnification. If 60 diopter, it's 1 times magnification. If 78 diopter, then less than 1 times magnification. If 90 diopter, then 0.66 times magnification. That's simple. Okay, just don't think. And another magnifying thing that we have to use is slit lamps magnification. Allow the 5 times greater area to view than the direct ophthalmoscope, because the lesser the magnification, if magnification goes lesser, field of view increases. That's simple mathematics, isn't it? So finished. So field of view is 12 degree or 2.23 times than the direct ophthalmoscopy, and provides monocular view of 70% of the retina. So that's the funny thing. Okay, it's always there. Patient's retina, lens, and this is the image plane or somewhere in between image plane, and observer focus on this image plane. That's why we call indirect. So what is the advantage and what is the disadvantage? Advantage is wide field of view along with a good magnification and real erect image. Disadvantage is the lack of stress in this monocular. Okay, binocularly it's very good stress and inability to conform to the standard current here. So what is the procedure to use? The instrument is made steady against the patient forehead using the forehead rest, and patient is asked to look across the room. Examiner is standing facing seated patient, and patient is of instrument is held approximately 18 mm from the patient's eye, allowing the eye light source to be focused in the pupillary plane. Illuminate fundus. Then what happened? Then continuously variable focusing lever can main manipulate or to produce and maintain a clear view of the patient's fundus. Then effective approach of being to being by examining the optic disc, and there are a lot of things that we can see. Yes, that's a procedural thing. Any pigmented lesion and this all thing we have discussed already. Great filter. So binocular indirect ophthalmoscopy, which is major thing that we already always do, is with the slit lamp and all these things. So basically, the modern binocular consists of headrest and containing light and viewing ocular. So we can do from this, or we can do from 90 diopter and slit lamp. Okay. So indication is always far better if small pupil is there, opacity is there, high myopia, and all these things is there. Principle same, but seeing binocularly, yes, stropsis is there. So basic thing is stropsis system is hand. Okay, it's always there. So a great indirect illuminated fundus at the lens focal length is always there. So basically, light comes from here, retina, and from the condensing lens, aerial image is formed between the binoculars and the patient, and we focus on the aerial image by slit lamp or by whatever headband, and that's we call indirect. So image, so see, it's not that big thing. But in emmetropia, emergent ray illuminated from retina is parallel. In hyperopia, they were diverse. In myopia, they would converge, isn't it? So by focusing the lens principle, thus the inverted image is formed on the condensing lens. No matter what, there will be an inverted image because we have power lens like 20 diopter, isn't it? It's like you have to have hyperopic more than 20 diopter. It's oh, very rare. In hyperopia, diverging lens. In myopia, converging light is coming from the out. So, in conclusion, real inverted and what do you call it? Magnified image? Oh, I don't know. Magnified or not. It's dependent on the lens, power of the lens, isn't it? So magnification depends on three things. One, dioptric power of the condensing lens, focal plane of the relative eye's position, and the patient refractive error. These two things basically plays very little role. First role is dioptric power of the condensing lens. Okay, so that's the formula, which is very simple formula. So field of view, larger the diameter of the lens and larger field of view, and field of view increases with the increasing condensing lens power. That's very important. Field of view of 20 diopter is lesser than 60 diopter, and lesser 60 diopter, 70 diopter, and 90 diopter. As increases, field of view increase. At the same time, if we want to increase the field of view, we have to take larger diameter 20 and then larger this and then this larger and then 90 diopter is the smallest because 90 diopter already has field of view larger because of its high power and less magnification. So procedure is minimum dilatation. Examiner is placed instruction head and adjust the IPD and condensing index is held such that it can face examiner position above the head and maybe sitting in the supine position. And sometimes this procedure can be done in the supine position and best is done with the supine position. While viewing the fundus, condensing is slightly tilted to displace enemy reflection. We know that, isn't it? The reflection, if we tilt the reflection, then tilt the lens, then reflection goes by 2 times away. So that's very helpful. The retina should be examined in quadrant, primary position, superior, nasal, and everywhere. Okay, fundus can be seen laterally reversed and vertically mapped. So basically, advantage is large field of view, lesser distortion of image, easier to examine frequent eye examination, 3D stroboscopic view because bright light, optical property useful view in case of hazy media. Disadvantage needs pupil dilation, hence the inappropriate patient with the shallow AC needs lot of experienced masters and limited magnification. That's already so. We use slit lamp, then magnification will be okay. Okay. With binocular indirect ophthalmoscopy or fully dilated pupil, it is possible to view fundus all the way to oral serrata. That's very important point. So landmarks that can be seen in the indirect ophthalmoscopy is vortex vein sample and long and short ciliary knobs. Okay. So basically, there are four vortex vein and a lot of air pigments. I don't want to talk to you about this. Okay. This is short ciliary arteries, nasal ora serrata, temporal ora serrata. There you have to discuss. We have to discuss this in another presentation in anatomy. It's okay. So there are some peripheral retinal lesions, that retinal tears that I think I'll show you. So lattice degeneration, myopic changes. This indirect ophthalmoscopy is very useful. Regmental retinal detachment and tractional retinal detachment. Okay, so the difference between direct ophthalmoscope and indirect ophthalmoscope. Condensing lens in case of direct ophthalmoscope not required. Goodness, required in indirect ophthalmoscope. Examination distance as close to the patient as possible for the field of view and at arm's length definitely. And image in case of direct ophthalmoscope virtual and erect, exactly opposite real and unblurred in case indirect ophthalmoscope. Illumination not so bright, not useful in hazy, but at the same time indirect, bright and used to hazy. Area in a focus is about 2 disc diameter. Is it? Oh, yeah, sometimes. And about 8 disc diameter is very important. Okay. Stereosis absent in direct ophthalmoscope. Is present in indirect ophthalmoscope. Accessible fundus view slightly beyond equator, slightly, but is up to the oracida or peripheral retina in indirect ophthalmoscope. Examination through hazy media not possible, or yes, is possible, but image is not good. But indirect ophthalmoscope is definitely possible. So these are the things for the direct and indirect ophthalmoscopy, main optics and the difference, and slightly about the lenses and how it works. Okay, I haven't gone through exactly point to point procedure. It's better to go from books, and this is a great book for this. Okay, just go from the book, which is very helpful for your clinical posting. Okay, this done. Choose.